So, you know, I hesitate to put this up because I don't think it has lots of science about it. This is Michael O'Donnell's Health Promotion in the Workplace textbook, and these are his estimates of what a basic program costs, what a comprehensive program costs, and what a BEST program costs. BEST is sort of world, you know, the most that anybody's doing, including having gyms on site and paying for flu shots and lots of communications. And by the way, you guys will have these slides and feel free to send them out to everybody. And I've updated these. If you look in the textbook, I've updated them to $2,008. I think the last time I looked, you were at about the $70 per employee level. King County's at about the $260 per employee level. And I tell you that just to give you a sense of where you are and what you can expect from it. You know, and so what does it cost to insure a family of 4 these days, by the way? What does it cost, the whole package, including what they pay and what we pay? So what? It's about $10,000 a year. Okay? And this is $260 a year. So, you know, I want to put this $260 in perspective. I mean, $10,000, you know, it's we're not in that league. So, okay, now I think part of the reason that Kathleen asked me to come here is that I have some strongly held views about some things, and I think that they sometimes are seen as being provocative. And so I want to provoke you a little bit, and not to say, mostly I just want to make you think. I'm not going to give you the answer here, because I don't think there necessarily are answers, but I do want to be a little bit provocative. Let's talk about biometrics. I mean, I know you're doing biometrics, so let's talk about it and think about it together. I mean, we'll talk about it. And you know, biometrics is lots of things. It could include measuring weight, but it certainly includes measuring blood pressure, lipids, and blood sugar in the workplace. So why would we do it? Okay, why would we do biometrics? Well, would we do it to screen? Well, I said to you before, screening is actually not the issue. You know, if you, people get screened in this country. You can't touch the healthcare system without having your blood pressure taken. And so 95% of people tell us that they've had their blood pressure checked in the past 2 years, which is what the recommendation is. And 85% have had a cholesterol check within the past 5 years, which is what the recommendation is. So, and actually, blood sugar screening isn't even recommended by the U.S. Preventive Services Task Force for the general population. It is for people who are obese, but not for the general population. Go look it up. I'm not making this up. So screening, I'd say we don't have a good basis for doing screening. I mean, if we were going to spend the money on biometrics for screening, we'd be better off spending the money on drugs, actually, for people who are already diagnosed, who aren't getting it. So the second thing is, maybe we're doing it for evaluation, right? And that's a reasonable notion. You know, if we could say that the average blood pressure in our population had gone down even 3 points, you know, we got a good representative sample, we could say that would be a big deal. We know from the science how much of a difference that would make in terms of heart attacks. We could estimate that. The problem we have is that the way biometrics gets done in most workplaces is you get 10, 20% of people to do it. Are those 10, 20% of people normal? Well, they're not normal. There are people like you and me that are ultra health conscious and show up for these things. They aren't the average person. And also, they change over time. So if you try to compare the 20% who come at time A to the 20% at time B, they aren't the same people. And so you really have no idea whether or not you really lowered blood pressure or whether you just got a different group of people. And I mean, just to give you a practical example, you know, I worked with one of the auto companies, and they told us that their smoking prevalence was something like 19%. And we knew in that state that the prevalence of smoking in people in that socioeconomic class was about 35%. Well, we looked at it. It turned out it was all managers who had filled out the survey. And none of the rank and file were filling out the survey. So that's the problem when you get just the people who show up. So what about fostering self-monitoring? And that actually, I think, is a reasonable thing to do, fostering self-monitoring. And the way that we just heard about it from the Attorney General's office would be the way I would recommend we do it, where you have the capacity for people to do it. But if you're bringing in the troops once a year to measure blood pressure or measure blood sugar or measure lipids once a year, that's not self-monitoring. This stuff needs to be measured for some people multiple times a day, and once a year is not going to get it done. And so again, I question whether it's the best way to spend limited resources when you're bringing in the troops from outside and collecting the data expensively, and it's not even connected to the clinical system. HRAs, another topic. So what are they? Well, health risk appraisals are brief questionnaires. They assess behaviors, usually lifestyle and clinical behaviors, although sometimes we use them to assess people's diseases. And they offer feedback on risk factors. So they tell you, you're overweight and that's bad for you and you should lose weight. I mean, that's what they do. So why do that? So what about changing behaviors? Well, actually, David Anderson, who's leading Light at Stay Well, one of the bigger companies in the country, published an article in 1995 where he reviewed the literature and said HRAs don't change behaviors. And the CDC has just finished a review where they have looked at the literature and said HRAs on their own don't change behaviors. And when you think about it, this is not actually all that surprising. I mean, so you fill out a piece of paper and it tells you, you know what? You smoke. You probably didn't know that, but you smoke. And you know what? It's bad for you. You probably didn't know that. And you know what? You should change. Or it tells you, you know what? You're 30 pounds overweight. You probably didn't know that. I mean, so on the face of it, why would you expect this one-time thing to actually, for the big things we're talking about, change behavior? I'm not sure I would, and the literature says that it doesn't. So how about evaluation? Well, we get back to the same problem we had with biometrics. The last time we looked at your data, you're getting less than 20% of people to participate in your HRAs. And so it's not a very useful evaluation tool for the same reason that the biometrics aren't a very useful evaluation tool. Those people are worried well, and you don't know from time A to time B. So here's the third reason that we might want to do HRAs, and that is to connect to coaching. And that's what they're doing in King County. So they get 90-95% participation in their HRAs, and then about half of those people are shunted over to coaching, individualized coaching around their risk behavior, so physical activity or smoking or whatever. And the literature says this works. And so if that's what we're doing, that's great. I think it's a good reason to do it. It costs $150 per person for King County to do it. It's one of the major reasons that they're up at the 260 level as opposed to the roughly that range, rather than at the $70 level. So if you wanted to use them to connect to coaching, I'd say good on you, and you don't have to get everybody to do it. But otherwise, I have to ask what we're doing with HRAs.